Hi guys, week number 10. We're going to go on with chapter 11 up to Parkinson disease. But before that, I will give you some feedback about your LOs and a couple of announcements, and then we'll go on with what we have to cover today. So I have my notes here. LO 25. LO 25. 83%. There's a question about statins in myalgia, right? It says commonly, the keyword in our book is may. So it was a kind of trick question over there. LO 26, 93%, very well. LO 27, 76%. There was a question about disturbances in proprioception that could result in increased or decreased stability. Go to page 484 and you'll figure out the answer to this question. So let's not very high scores in the 2 out of the 3 LOs, and I can see a pattern of people harassing them again. So please take your time. Okay. Now, advising tomorrow. If you are one of my advisees, please. I'm circulating a Google sheet, so put your name in there and let's talk. Let's visit. If I'm not your advisor, please try to find your advisor. Okay. So no office hours tomorrow because of advising. And one more thing I want to talk about is the fourth synchronous meeting. I will probably be traveling on the 21st when it was initially scheduled. So I moved it on the 20th of April. I'm going to show you that in a second. So that's what I have. Again, just please, let's finish strong with the LOs. Don't do that, okay? Appreciate it. So we're here. And this is what we're going to do today, Parkinson disease, up to Parkinson disease. And what you have for next time is LO 28 and 29. I'm finishing up the chapter 11, and probably the TAs I'm going to do chapter 12. And so this is for next week, and then we're going towards the PDOs and what you have to submit. So please, I hope you're working towards your PDOs. If you don't, let me know. The time is coming. You need to be working on your PDO, okay? You definitely need to working on your PDO. Let me know if you have any questions, okay? Time is coming. It's like 3 weeks. So do what you need to do. Be proactive, please. This is what I was talking about, the synchronous meeting. So instead of the 21st, I moved it to the 20th, same time. It's at noon, 12 noon, okay? All right. Stop sharing this and start sharing our PowerPoint slideshow. So this is where we are, HIV now. And I'm gonna go and keep it as short as possible. I don't like very long videos because I know you don't like them either. So we have the antiretroviral therapy, ART, okay, which has helped a lot with life expectancy. So it has been very beneficial. However, we have some side effects, as you can see, abnormal distribution of body fat and so on and so forth. So these clients are unique in that sense. Now, because of the new treatments and the way the infection is happening now, we see HIV occurring predominantly in specific minorities and groups of low socioeconomic background. And that is associated with specific BMIs, muscle strength and mass, the positioning of the body fat. So this is something you should think about when you are prescribing exercise for people who have the HIV. Now, one last thing over there for this slide is the CD4 cell count or viral load. I want to talk about it. Those two things are different. The CD4 cell count has to do with white cells, right? And if it's low, it means what? That your immune system is weak, right? And the viral load, it means has to do with the particles of HIV. And if it's high, it usually means you just got it or you're not treating it well. So we need the CD4 high and the viral load low. That would be the ideal. Oh, sorry about that. Okay, so aerobic and resistance exercise provide important health benefits. So they should work out, okay? Now, because they have other comorbidities coming with HIV, the consultation for somebody who's specialized is recommended for sure before, of course, we talk about any kind of exercise testing, right? Acute infections, of course, if they have acute infections, we have a high probability of transmission, right? So we need to take that into consideration if we have to do some kind of exercise testing and postpone the testing. And when we're talking about cardiopulmonary exercise tests, again, we need to be careful, although it's not going to be transmitted through saliva, but there is always a danger of oral infections. Okay, so we need to be very careful because they also have cardiac dysfunction, BP, and ECG monitoring are recommended. And if they have peripheral neuropathies, we need to adjust accordingly. Now, let's talk about the stages. When we have asymptomatic, we usually do things as we do for anybody else. When they're symptomatic, as you can see, we expect lower responses to exercise, all of them. Physical and mental benefits. And also what's important, there is no study that proves that there is some kind of immunosuppressive effect because of working out. So it's not that if we work out, our immune system is going to get weaker. So that's not a thing, right? And some of them, as you can see in some studies, they show more robust responses than in the health population, right? Which is amazing. So here, not a lot of things to talk about, other than if you go to aerobic type, you see that presence of osteopenia will require weight-bearing physical activities. And I hope you know what is osteopenia. If you don't, we're going to mention it in a little bit because we're going to have to cover this condition as well. All right. Of course, contact and high-risk sports, not recommended because there are side effects of the drug, slow rate, asymptomatic is fine, right? The goal is to facilitate them to work out as any other individual, especially asymptomatic, okay? No currently established guidelines regarding contraindications. When they are symptomatic, no, supervised is definitely recommended. And if they are doing strenuous activity, then that's another reason why the supervision is recommended. They should report fatigue because that's a thing with people with HIV and AIDS, right? Now, that regular monitoring should be regular. So we need to regularly monitor any kind of benefits they're getting from the PA or any kind of symptoms they have. They want to report anything that is going on. All right. We're going to talk about intellectual disability, and then we're going to pair it up with DS, Down syndrome, okay? So here, we used to call IDMR, mental retardation, and it's very common before the age of 18, okay? Now, two limitations, which is important to mention here. Intellectual functioning, that happens if you have that, right? And you can see there are two subcategories, and adaptive behavior. That's another issue we have, with this kind of patients or clients. Etiology, for up to half of the cases, we do not know. But you see the major causes right there, and I think you know what all of these mean. You see there are many subpopulations, like the Fragile X syndrome, genetic disorder that leads to ID. PKU is you can metabolize the amino acid of the PKU. And the main thing now that we're interested in, and most exercise has dealt with, is intellectual disability with or without Down syndrome. Okay, vast majority, as you can see, have mild ID, which is great. And if they do have mild ID and they don't have Down syndrome, the life expectancy is approaching the one of the general population, which now when we talk about the cause of morbidity and mortality, you see that the cardiovascular complications, obesity, and physical inactivity are pretty much the same of the general population. Pre-participation screening, the same, except for the ones that have Down syndrome, because they have that instability, you see, atlantoaxial instability, right? C1, C2, that's really important. They have to be familiar with the test. It has been proven that the more familiar they are, the better the results of the test. So they may need to visit. You may need to be very responsive to whatever issues they may have. So keep that in mind. They need to feel valued, and that's important for them. Okay, they need to feel safe. Appropriate tests for them. Cycle ergometry protocols should not be used due to poor motor coordination in creating consistent forward pedal movement. Okay, we'll see in another case that ergometry protocols are recommended. Exactly the opposite, just in a second, all right? If they have DS, we can use the formula that we do know, right? The Fox's formula, 220 minus 8. There's another one here. You don't have to remember it, but here it is. ID, but without DS, not many difference in aerobic capacity, but muscle strength is lower, right? If they have DS, they also have lower aerobic capacity, along with muscle strength, and they're overweight and or obese. Ballast testing is important for that population. Here you see the recommended and not recommended tests for fitness tests for this kind of population concerning cardiorespiratory fitness, muscular fitness, anthropometrics, and flexibility. You see anthropometric flexibility is pretty much the same. What is important to see for the muscular strength and endurance, for example, you see that we're using machines and not free weights. And the cardiorespiratory fitness, no cycle ergometry, no arm ergometry, no treadmill, but walking is something that should be used. Vine Airdynes, right? That's the bike. We could use that. That's pretty much it. All right, these are some formulas. You don't have to remember them. Here, what is important is, I guess, if we go all the way down, machines, as we said, are preferable to free weights, resistance. And then when it comes to aerobic, primary activity is walking, okay? All right, focus on muscle strength. That is necessary. Yoga is great, but we talked about they may have some issues, right, with stability. So we need to make sure that's not an issue, or in whatever activities, exercise, movements we prescribe that have to do with yoga. Additional encouragement, we talked about that. They take a lot of medication, so we need to understand the side effects of those. And neuromotor exercise is important for them. We've already talked about stability. They may have issues with falling, gait, and so on and so forth. They may have attention difficulties, which means that it may be hard for them to follow instructions whenever it's about a test or actually doing an exercise. Familiarization again is important. They need to enjoy it if you want them to come back, and group activities may help for that as well. Low levels of aerobic capacity and muscle strength. If they have DS, again, they have low HR max. Why? You see, dumping catecholamine response to exercise. When we exercise, we secrete hormones like the catecholamine that it's a reaction to exercise, right? If that reaction is not as intense, it doesn't excite our nervous system to increase HR. So it has an effect with the HR max, right? Hyperflexion, hyperextension of the neck, we talked about it, no. And some muscles may be hypotonic, right? So your muscles right now are normal. They can be hypertonic or they can be hypotonic. So we need to take that into consideration, and especially when we also have joint laxity, okay? Some of them may be shorter, some limbs shorter, malformation. That should be taken into consideration, of course. And if they have ear pathologies, which is not uncommon, we have to be careful when we're prescribing aquatic exercise. All right, let's move to CKD, chronic kidney disease. So in order to be diagnosed, we either use a urine. So that will mean that we're using microalbuminuria, okay? Or we can use blood sample and GFR. So GFR is how much blood is going through our kidneys, and then the first one is how much albumin is going through our kidneys, okay? 20 million Americans have CKD, and here is the grouping. You see that the G5 is the worst. We're talking about kidney failure. So you see there, it's less than 15 what milliliters per minute, right? So we're talking again about how much the quantity of blood that goes through our kidneys. That's what this is talking about. CVD, highly correlated with CKD and mortality. So we need sometimes to make sure that's okay before we prescribe any kind of exercise testing. And the worst case, as you can see, is the ESRD, end-stage renal disease, and that's the stage 5. So we need to be careful, especially with those patients, but you will see in a little bit that most of the research has been done with the stage 5 CKD, okay? Which, as you understand, they have low functional capacities, lower VO2 peak. However, exercise can be really helpful. Medical clearance, of course, multiple medications, again, same thing. If they are 1 to 4, maybe we should use standard testing procedures. And if they are into hemodialysis, as you will see in a little bit, in the non-dialysis stage is better. And here we see the AV fistula, right, which is an abnormal connection between an artery and a vein. And that is something that you can, in this case, it is made in a way to help with the hemodialysis, okay? That's the point of it. All right, so some people can do CAPD, continuous ambulatory peritoneal dialysis, which is something newer, and you can kind of do it by yourself at home. You don't have to go somewhere. Usually happening at night in some cases. So there's a fluid that goes into your body. There's stoma, right, hole, and then that helps with filtering your blood, and then you take it out and you move on with your day. For some time, though, you have that fluid in your abdomen, okay? So if, as we'll see now in some slides later on, you could do it while you have the fluid in your abdomen, but it may be uncomfortable or whatever. So if you can drain it, that would be great. Again, take a look. You can look it up, see a picture of what it is. It's pretty cool. This invention is pretty cool and pretty helpful for people with CKD. So we have the classic maintenance hemodialysis. So there, because we can have that can affect the HR peak, right? R peak is another way to measure intensity. Note 1RM, because you can see we may have Gaussian fractures, and that's when a tendon or a ligament pulls off a piece of the bone, right? Definitely don't want that. Here, I'm sure I wanted to talk about something here. I guess I don't remember. Yes, the 3 to 5 minute bouts of intermittent exercise. So these people may not be able to tolerate the 20 to 60 minutes, okay? Which is exactly what we're covering right here. And also consider the clinical status of the individual, okay? You see here the individuals with CKD, especially the ones with end-stage renal disease. Progression is the key word here, and they have to go into a higher volume, okay? Okay, we're going to read all of this now because it has to do with hemodialysis. Exercise should ideally be performed on non-dialysis day. Performing exercise immediately post-dialysis may increase the risk of a hypotensive response. During any aerobic exercise, it may be beneficial to use RPE. Patients may exercise the arm with permanent AV access, but should avoid placing weight or pressure on the access device. Measure BP in the arm that does not contain the fistula. And if exercise is performed during dialysis, it should typically be done during the first half of the treatment to avoid hypotensive episodes. Okay? We talked about peritoneal dialysis. If the fluid creates discomfort, drain it. If you have been a recipient of kidney transplant, or if you're working with somebody like that, during the period of rejection, exercise should be continued, just reduced, but still go on with exercise. All right. MS, multiple sclerosis, chronic inflammatory autoimmune disease, right? That hits the central nervous system, and women are getting hit way more than men, 2 to 3 times more. Okay, etiology, who knows? Okay, we don't really know. Now, categories. Relapsing, most of the cases. Periodic exacerbations followed by full or partial recovery. Okay, primary progressive, 10%. Continuous disease progression from onset with little or no plateaus, or improvements. And then a mix of those two, progressive, relapsing, so it's progressing, but it's not continuous, it's through relapses, okay? Symptoms, is there anything we don't know? Excuse me, optic neuritis, inflammation of the optic nerve, and nystagmus, uncontrolled eye movement, paresthesia, spasticity. We talked about spasticity before, right? It's like abnormal sensation of the skin, okay? These are the 3 types, but the progressive has been broken down into 2, the primary and secondary, same thing though. This is the rating. As you can see, 10 is death attributable to MS. They have lower exercise tolerance and higher perceived fatigue, low maximal aerobic capacity, which keeps going down. HR and BP responses may be blunted, so we need to be careful about that. Decreased muscle performance, everything is bad, right? Lower isometric and dynamic power production. However, with resistance training, we can definitely see improvements. Testing. We need to review the history and the list of medications. Don't do it during acute exacerbation. We need to monitor the signs of paresis, fatigue, overheating in general, Paresis is the partial paralysis, right? Earlier in the day may be better. And here you can see is another case here. Bicycle ergometer is the recommended method, okay? Because it helps them with balance and coordination. Even recumbent stepping ergometer may be the case sometimes. Most strength and endurance, we can use the standard protocols. Assessment of flexibility is important, especially if we're talking about increased muscle tone and spasticity. So a goniometer can really help us with that. And here, nothing too fancy about that. Functional activities is very important for them. We should use RPE, and for fatigue, the only 0 to 10 scale, which I'm going to show you in the next slide. When they have exacerbation of symptoms, decrease any component of the FEET principle, right? And if there is a reason for that, just adjust your prescription to full muscle recovery. This is the only scale from 0 to 10. Once I'm warmed up, that's also always better before stretching. Slow and gentle passive range of motion, definitely. And if the muscle is spastic, okay, increase the frequency and time of flexibility. Spastic, okay. Medication and the side effects should be into consideration, which we know systemic fatigue, which means fatigue all over, right? It's not local, it's everywhere in the system. Is something common, but as they keep exercising, it becomes better. They don't drink water because they have bladder control issues. Make sure you know that, and make sure you encourage fluid intake. Some of them may have cognitive deficit, which again affects them following instructions and so on and so forth. Udov's phenomenon. So here we have an exacerbation of all the symptoms and signs that you're feeling, and it has to do with elevation of body temperature as well. So one of the ways to attack that is by cooling the individual. So have that in mind. All right, osteoporosis. I think that's the last one for today. What is it? So the definition, or the definition, the main characteristic is low bone mineral density, right? A lot of people in the United States have osteoporosis, and the stage before osteoporosis is osteopenia, okay, which is lighter in terms of severity. Exercise can delay the onset of osteoporosis and reduce fracture risk, but you can see at the very end that it is the primary non-pharmacological treatment for prevention of osteoporosis, which is awesome. All right. Cycles like ergometry as an alternative to treadmill. They have issues with vertebral compression, which affects ventilatory capacity, and then because they will have a forward shift, right? That affects balance. So we need to be careful. Maximal strength testing may be contraindicated, and there are many different kind of balance tests. This is a link that can show you different ones from CDC. All right, here, weight-bearing activity preferred all the way down to aerobic. That's important. Yeah. It's difficult to quantify exercise intensity, so we need to be careful about that. It's hard. We need to, a lot of times it's a trial and error situation. No established guidelines regarding contraindications. Prescribe moderate intensity that does not cause or exacerbate pain. Definitely activities to improve balance. And this is important. Even the frailest elderly should remain as physically active as his or her health permits to preserve musculoskeletal integrity. Okay? If they stay home, if they stay in bed, that's probably the worst thing they could do in terms of their condition. All right. No, I'm not going to do Parkinson. I'm going to leave it for next week. So yeah, that's all, guys. Um, let me stop sharing this. So I want to remind you that we have 2 LOs for next week, and advising tomorrow, no office hours, and don't forget that I changed the synchronous meeting from April 21st to April 20th. Thank you so much. Have a great week, and if I don't see you,